Good afternoon, everyone. I welcome you for the fifth STG session on standard treatment guidelines of diabetes mellitus. I welcome Dr. Narendra Pal Singh and Dr. Sangeeta Sharma for this session. I also welcome Dr. Jain Srivastava sir, NHSRC, UPS Division, NHSRC.
Also, I welcome all the participants.
For this fifth session.
Sir, I request to address
the participants of the session.
Good afternoon, sir. Am I audible?
Yes, sir. Yes, sir.
Because today I'm facing some technical glitches. This is the third system I'm trying out. So that's why you must be seeing the name differently. So very warm welcome, sir. And we are extremely grateful for your valuable time and to be with us to talk on this important problem of diabetes mellitus, which you know it better. The whole country is grappling with. And India has the dubious distinction of being the capital of among other honors, this is also people call that diabetes capital. So at the outset, in fact, just to give you the brief overview, that today we have got all the district hospital people connected with us, also the quality persons, and in more than normally it happens that if though you may find login limited, but in one location it is more than many people who are attending. So this was the initiative which was started. In fact, we were nudged by Professor Sangeeta Sharma that let's do something for the public health system, and in that context we thought jointly that let's take up a contemporary problem, which in fact the people sitting in the peripheries, where at most there is only one single physician or maybe general duty doctor over a period of time in a particular working environment, is grappling with. And we know, as I say, I know, sir, your profile, that you have been the part of, other than the JIPMER Pondicherry, Maulana Azad Medical College, and still you are an eminent academician associated with the medical teaching. And we all felt somewhere sitting in the apex institutions that, the common problems, a case of diabetes, we know, could very well be stabilized if the people are aware, they know that what all screenings are required to be undertaken and how it needs to be monitored. And with, of course, that goes without saying, certain lifestyle changes. Another challenge we have been faced with that rational prescribing of the drugs and holistic, advice to the patients, to the families, largely have been missing. We know, I will not bother you all with too much of data, but these are the practical problem when we, as a part of National Health System Resource Center, which is an apex technical support organization with the Ministry of Health and Family Welfare, besides helping the ministry in coming out with certain policy documents, we also undertake the midterm evaluation. We periodically visit the states, and our counterpart in the states are State Health Resource Center, which normally advises the state functionaries, their principal secretaries, mission directors, director health services, that what programmatic corrections they got to be making. And we realize the level of unawareness, people not knowing that how to manage these lifestyle diseases in general and diabetes mellitus in particular. They think that they're merely just getting the drug will be the panacea of all the ills, whatever they have. So once again, we are extremely privileged and grateful on behalf of the state to have you sir, and also Professor Sangeeta Sharma, who is a force behind this initiative to have this useful session. Madam always ensures that there is a session on the rational prescribing, conduct of the prescription audit. There are different sub-dimensions which she has added beautifully over a period of time. We look forward to your valuable talk, sir. and look forward to continue your association. If you can spare some time in to be a part of our expert group member, will be extremely privileged. Once again, sir, thank you very much.
Thank you, sir.
Uh,
And it will be my honor to be a part of you.
Thank you, Dr. Srivastava, for your kind introduction and setting the scene and giving a description about the participants as well. And thank you, Dr. N.P. Singh, on behalf of both the SPRUD and NHSRC for sparing time. And I hope we will be, we ourselves also are going to learn, because he has a rich experience from both public as well as private sector. So there are different barriers and facilitators for management of diabetes in different sectors. So maybe I'm sure the participants will enjoy this, and we'll have a good question and answer session. So with this, I think I can start with the response to the quiz that we gave. We can, I think this is the one. Can you see my screen? Just a minute. Let me do it again. Can you see my screen now?
Yes, ma'am.
Yes,
Okay.
madam. It is visible. Healthcare professional cadre.
Yes. Okay. This is, just now we have got around 185, 86 responses from, the participant side. And this is how the distribution is. Most of you are doctors, but we have nursing and pharmacy quality manager personnel here. This is the distribution of and majority are from the public sector, but I see around 15% from the private sector, and other representing other fields are there. And most again, the distribution of the participants is from different levels of healthcare. We have people from medical college, as well as people from the district level hospital and CSC, and a good number of people from the PHC dispensary or the clinic level. So I think we have a good mix of people here from different levels of healthcare. Now, the first question was, which of the following statements about dosing in children are correct? In this, the questions were around the different ways of measuring a dose in children. If you see, um, uh, 27.5% and around 60% of you have answered this correctly, but some of you have said a spoon from the kitchen can be used for a measuring as a dose. Kitchen spoon should never be used for dosing in a child, because the size of the spoon can vary from 2 ml, 3 ml to 7 ml, 8 ml. Different households have different types of spoon, and also there are different types of spoons. So as a practice, one should not be using kitchen spoon as a measurement for the dose. And if dropper can be used accurately for 1 ml dose only. If you have a dose beyond 1 ml, the dropper is also not adequate. Calibrated measuring cups can be used for dosing, but if you have but this would be measuring accurately if the dose is above 3 ml and 5 ml, around 5 ml. But if the dose is around 2.5 ml, the oral syringe becomes a better way of measuring the dose. Because this is important, because children can be underdosed as well as overdose easily, just because we haven't used the correct measuring device for giving a dose to the children. Now, there is a second question about a 6-year-old boy accidentally consumed kerosene. State whether the following statement is true or false for the management for this patient. Gastric lavage was recommended for this patient. You rightly said around 60% have rightly said gastric lavage or induction of vomiting should not be done in case of kerosene poisoning. There is a risk of aspiration, and it can cause damage. So then next question was regarding the management of acute watery diarrhea. Here different types of statements were given. ORS is the mainstay of treatment. Although the response is good, 86%, but I was expecting 100%, because when it is acute watery diarrhea, it is usually viral in nature, and the immediate complications are due to dehydration. So it is not the infection, it is the dehydration which can lead to death or other complications. So correction of dehydration is the mainstay of treatment. But some, around one fourth of people still feel that the any diarrhea with fever should be treated with antibiotic or antiamoebic agents. Fever or not fever, the acute watery diarrhea can be associated with some, because it's viral in nature, so some fever could be there. So fever is not the criteria. And secondly, both when do we prescribe antibiotics? When there is a bacillary infection, dysentery. So antibiotics will work against the bacteria, and anti-amoebics work against the amoeba, when you are suspecting amoebiasis. But rarely, if you find, evidence clearly shows that both bacillary and amoebic infections do not happen. It's quite rare. So but giving this treatment with both antibiotic, the ciprofloxacin and ornidazole or tinidazole with antiamoebic is not justified. Similarly, yes, when you have a severe dehydration cases, and you have had some reporting of cases of cholera, definitely yes, there are exceptions. Here you can use antibiotic. For cholera you can use this. Probiotics, many of us feel that they are not the mainstay of treatment. They have been found, there is a different mixed kind of reports, results in the literature. Probiotics can be added to the treatment, but they are not the mainstay of treatment, because there are different strains there, which probiotics are available in different the colony count and the strains. Some evidence is there, but not as the mainstay of treatment. Similarly, a child who had diarrhea for 12 days, dehydration, weight loss, look for other causes rather than just giving them antibiotics and antiamoebic agents. Then there was a question about which of the following statement regarding fever is correct. We all of us have different notions about fever. What is fever? I think, and I'm correct, in my observation is correct, we are so we think that 98.4 is the normal temperature. Anything above is fever. No, it is not so. There are variations. This is the average body temperature, and it may vary according to the time of the day, before activity, after activity, morning, evening, like that. And how do we measure this temperature is also important. Rectal temperature is quite accurate. Oral is less than the rectal, and axillary is even lesser than the, so you have to make adjustments for this. So how are you measuring this temperature is also important. So uh, we will treat and consider this as fever only when it is above 38 degrees centigrade. Below 100 degree or 38 degree, antipyretics are not justified. Low grade fever should not be treated with antipyretic otherwise, because fever, if you look at the pattern of the fever also guides you about the diagnosis. So if you suppress this fever right from the beginning, you will not come to know the trends in the fever peaks, how many peaks were there in a day, what time did the peak occur, how much was the peak. All these details help us in making a clinical diagnosis as well. So low grade, don't attempt to treat the low grade fevers, with antibiotics. Then fever in children is defined as an oral temperature of, yes, but only 37% have said this correctly. A person with high grade fever and chills should be dressed in warm clothes. No, usually I know it's difficult. A person who is having chills, but warm clothes will make the body temperature rise further. Then, which device do you use for measuring the fever? Nowadays, a lot of digital thermometers are available. They can be used accurately. They give you the temperature accurately. But these forehead strips, liquid crystal strips, applied to forehead are not accurate, so should not be used for measuring temperature in children. Now then, in children more than 3 months of age, temperature more than 39 degree only needs antipyretics. Again, like in adults, I said 38 and above, antipyretics should be given. But in children who are more than 3 months of age, low grade fever is not encouraged with treatment with antibiotics. Then, in case of high fever more than 41 in a child less than 6 months age, IV paracetamol can be given. Again, one third of you have said this is incorrect. IV paracetamol is not recommended in children with below 6 months of age. And I hope you will keep this in mind. Even if it is higher, body temperature is high, you are worried about, you want to bring it down, then the lukewarm water sponging is better. But IV paracetamol is not recommended for this age group. Then children, they may deteriorate faster, and there are triaging protocols for children. And then amongst the triaging protocols, they have, a child with red flag signs should be seen immediately, or the child should be seen at the earliest, or you can defer and see the child in the OPD. So we should know the immediate red flag signs. You rightly said, if the temperature is more than 40 degree centigrade, yes, these children should be immediately examined. You see the armpit temperature, that is why I've given because axillary temperature is recorded is lower than the body. So at 39.4, yes, if it is resulting in a fever with seizures, yes, you should see the child immediately. A fever that keeps coming back, even if they last only a few hours, again there must be something. So this needs to be looked into. WBC count between 5,000 to 15,000, urine microscopy with less than 10 pus cells, and if diarrhea is present, stool microscopy is showing less than 10 per cell. These can be seen, there is no need to do anything immediately, but they can be seen at the earliest. Then comes to a total number of doses of vitamin A till fifth birthday according to RMNCs. I think all of you are involved in the immunization program, but only 50% of you have given the correct answer. A total of 9 doses is required. First dose is given along with the measles, 1 lakh unit, then along with DPD at 16 to 18 months, 2 lakh doses, and then every 6 months, 2 lakh units every 6 months till the fifth year. So that makes it 9 doses of vitamin A in children. Then then there was a question about a 12-year-old boy who was receiving phenytoin suspension. Recently, just because now the boy was able to take orally as well, tablets as well, so he was switched from phenytoin suspension to oral tablets. But then with as a result of this switching over from suspension to the tablet dosage form, the epileptic seizures returned. And this was corroborated by the serum phenytoin levels. Earlier it was 24. Normal therapeutic range is 10 to 20, and it was quite okay. 24 was okay. But now with this switch over from suspension to tablet, the levels dropped. So what should you be doing? And this thing happens very commonly. The patient is stabilized on one dosage form, but then if you change the dosage form, particularly with some drugs like phenytoin, lithium, digoxin, thyroxine, change in the dosage form or even change in the brand name will make a change in the blood levels, and it can disturb the uh, clinical response. Like you see in this case here, the child started having breakthrough seizures. So but phenytoin is peculiar here, because it exhibits zero order kinetic. Up to a particular dose, the increase in dose will have a corresponding increase in the blood levels. But beyond a particular dose, if you increase it further, the increase in the blood levels would be disproportionate to the dosage levels. So with these drugs, one has to be careful, and whenever you are switching over from one dosage form to another, or with brand name, you need to be careful about this. So in this case, only a small increment, because the levels dropped to 14, and at 24 the patient had a good response. So a small increase only has been suggested because of this zero order kinetics. Then I think Dr. NP Singh is here. We will talk about the diagnostic criteria for diabetes mellitus. But still, all of I think these should have been 100% here. And this one, postprandial 1.5 hours blood glucose. I don't know. In all, I have read it like this, in all the textbook, in all the guidelines, expert consensus guidelines. We have read postprandial is 2 hours after meal. But somehow, for some convenience, I see, many people have started accepting 1.5 hours. I don't know whether you notice this 1.5 hours. It should be 2 hours. Otherwise you will be over diagnosing some of these patients, because the obviously in diabetic patient, the return to normal sugar is delayed. It's slower than the normal individuals. So if you do this GTT at 1.5 hours, it will lead to over diagnosis. I think Dr. NP Singh can elaborate further on this. Now coming to an because children are one of the special population groups. Similarly, the elderly are also a special, I'll be discussing about, what are the peculiarities that may happen in elderly patients. So in this severe community acquired pneumonia, and the patient had a high grade fever with green sputum, HR heart rate was high. So I think the first, the patient was put on amoxiclav intravenous, and the first, how do you assess response to therapy is also very important. Again, many of you have said chest X-ray. Chest X-ray at the beginning for diagnosis is justified, but chest X-ray cannot be taken as an assessment of response. not only in the immediate 3 days, but even after, you see, complete the antibiotic course for these patients, even after 15 days, there is no need for end of treatment x-ray, because radiological, if there is a patch in the lungs, this patch will clearance will take much longer than the clinical response. So we need to be seeing, whether the fever is down, respiratory rate is down, heart rate is coming down, uh, you know uh, chest auscultation, but not in the immediate 3 days. Sputum color is again not a very reliable way. I think I have made this point very assessment. We need to use the appropriate criteria for assessment of response to treatment. Otherwise, we will be, most of us, believe that the chest X-ray. So I have actually seen people getting these X-rays repeated after 3 days, 7 days, 10 days, 15 days. There is no need at all. It can be response can be measured clinically as well. I think, okay. Oh, yes, there is one more question here. Which of the following statements regarding gastroesophageal reflux disease are correct? Again, this is one very common problem that we see in elderly patients. Around half of you have said that acid reflux can present as a sore throat, hoarseness of voice. They can also present as asthma or chronic cough. Yes, they can present this. Now, coming to this retrosternal pain, heartburn, regurgitation after meals. Yes, these are the symptoms of GERD. But if you have read this question carefully, I said irrespective of frequency. Once in a while, external pain, burn will not classify as GERD. If it is present for more than 2 times a week, then only you will consider. So why am I saying so? Many of us then put the patient on PPIs, proton pump inhibitors, just because the patient has one episode, one of the episode, because I may have eaten something, or there may have been something. But if these symptoms are persistently there, then only it justifies treatment with PPI. And one problem with PPI is, commonly you will also agree with me that once the patient is on PPI, and we see that we find it very difficult to withdraw, for two reasons. First, that we don't make any attempt to withdraw. Second, even if we make an attempt to withdraw, patient will have rebound acidity, because all these while you have suppressed acid. And then once you stop this PPI, the pH of the stomach becomes acidic again. And now, if you, after a long period of having basic pH in the stomach, if there is an acid pH, of course the patient will have. And then, we get into that spiral of, considering, oh, that is why I gave him PPI, मैंने इसीलिए तो जरूरत था. That's a false notion that we have. It is just the rebound. If you prepare your patient well, or ask the patient to manage it for few days, perhaps you will be able to wean off from PPI. But वो rebound होता है, तो सब सोचते हैं कि हाँ इसीलिए तो हम दे रहे थे, and that reinforces. So break that cycle. And many of us also think that endoscopy should be done for all the patients. Endoscopy only should be done if the patient is not responding after 8 weeks of treatment with PPI, or the patient is having alarm features. Alarm features are like, the age more than 60 years, patient is having bleeding, patient is having dysphagia, odynophagia, or weight loss, unintentional weight loss is there. Endoscopy is needed. Similarly, proton, as I think I told you, proton pump inhibitors are not the first line treatment. You can, in a mild to moderate case which is infrequent, maybe you can treat it with antacid, maybe you can also try ranitidine for that. Sometimes even this gastric hurrying agent also work. So PPI are not the first line all the time, and only patient having this was correct, 2 or more times per week need PPI. So be selective in patients, for whom you put them on PPIs. Right now, I see, any painkiller in the prescription, any elderly patient having 2 or 3 other problems always gets a PPI. So that's a overuse of, and I'll tell you in the elderly how, this can be a troublesome if you, then efficacy of different PPIs differ, and newer PPIs are better. There is no difference in the efficacy of the PPIs. Omeprazole is as good as rabiprazole or esomeprazole. They are all having the same efficacy. The difference is in the preference for meal. OCID, the omeprazole, has to be taken empty stomach, whereas rabiprazole may be taken after meals as well. So that's the only difference, but the cost difference may be huge. So please do consider when you are choosing a PPI for a patient. I think with this I think this is over. We can have the question and answers later about this, and I hope I have made points clear here. Now coming to okay. My main presentation, we have had this. We all, can you see my PowerPoint now?
Yes, ma'am.
Okay, thank you. You all know essential medicines are those that satisfy the priority healthcare needs of the population. Therefore, they should be available at all times, in adequate amounts, in appropriate dosage form. This is important. We all take care of this. In appropriate dosage form means, all of us have, adult dosage forms in plenty. There is no problem. But when it comes to pediatric dosage form, usually I find there is a shortage, or because there are, I'll come down to that, because we feel that the children are small adults, or we believe that all tablets can be split into half or four portions and can be given to children. So if you think that we need to be increasing availability and accessibility to essential medicines, we need to look into this part as well. And rational drug use required, that everyone gets their treatment appropriate to their clinical needs in doses that meet their own individual requirements. So a child would require a liquid dosage form, or a inpatient, when needs intravenous, so maybe that is appropriate for him. And for an adequate period of time, if you have to give treatment for 5 days, 7 days, 1 month, 6 months, depending on the disease, it should be available for the entire duration and at the lowest cost to them and the community. We all know there is an overuse of antibiotics injections that we are very much worried about because of antimicrobial resistance. Then we are also worried about the medication errors that may happen because of the mix up of names, because there are several thousands of preparations which are available in the market with similar names, sounding names, and the packaging are similar. So there is a huge potential for medication errors with these drugs. And then on top of that, if we have wrong medication, multifold use, polypharmacy, and underuse is equally an irrational use. When you need a treatment, when you need to provide a treatment for asthma, epilepsy, we should be, if you don't treat that, even diabetes, I would say, many of us feel, have a belief, even I think patients do have that, they defer treatment for diabetes, कि अभी इसे लेना शुरू करेंगे तो ये तो लाइफ लॉन्ग लेना पड़ेगा, तो let me delay this as much as I can. So, and partly for this kind of belief in patient, I feel we the prescribers are also responsible, because we also take it that without knowing that it is the duration of diabetes that will cause more complications. Like that, current there is a lot of variation. We have just now seen that the responses to various questions, I think those were self explanatory. And if, as you know, prescribing is a complex task. It's not an easy thing. It needs diagnostic skills, knowledge of medicines. It needs the understanding principles of clinical pharmacology. Also, communication skills are needed, and we need to appreciate the risk and uncertainty. Unfortunately, most of the time, if you go back and do, all of you are supposed to do prescription audit. If you look at, I don't know, if you look at 100 prescription, you will find diagnosis written in only 1, 2, or maximum 5%, 10%. Rest all is symptoms: fever, headache, diarrhea. We don't make a diagnosis. Unless we make a diagnosis, the how can we expect that our treatment would be accurate? Although there is always some kind of uncertainty, we don't know how the patient is going to respond to a particular drug, but chances of success with treatment are more when we make a diagnosis. Yes, I understand. Sometimes on the first occasion, when you see a patient, you may not be able to make a diagnosis. But provisional diagnosis could be there, or you may have some differential diagnosis written there, so that anyone who who sees this prescription knows on what line were you thinking, and how were you planning to treat this patient. This is what I meant. Because the rational prescribing, if you want to talk about this follows a logical sequence from diagnosis to follow up. And if our diagnosis keep going here, why here, though I'm sure we cannot achieve that success. For example, many of times we do this empirically when we see septicemia patients, we UTI, or especially when they have bacterial infection. So we start with empirical, but then as the patient responds, or as the time goes, when you have laboratory investigations available, we need to narrow down the diagnosis and make appropriate choices. Otherwise, we are just fueling antimicrobial resistance by using these empirically. We saw just now all cases of diarrhea. In fact, you will find that there is a stereotype of prescription response will be there. All cases of diarrhea, I can bet upon it. If you look at 190 will have antibiotic and an anti-amoebic agent in the prescription. Please look back into it. We have already discussed this, because our goal is that the patient gets a cure. Or sometimes if we are not able to cure a disease, but we want to relieve a symptom, but without affecting the underlying condition, for example, headache or a diarrhea. Or sometimes if you recall your MBBS teaching, the teaching was always for a choose a drug which can target one or two or more symptoms. We need not have a drug for each symptom in the prescription. So this may happen with inflammatory bowel disease, arthritis. The patient may be having comorbid illnesses. The patient is put on, for example, arthritis patient, he is put on painkillers and NSAIDs. But at the same time, the patient is also having hypertension. Then the hypertension control will be disturbed, because a painkiller, they retain fluid in the body, and with increased fluid in the body, the blood pressure targets will not be achieved. So we need to look into this. How can we do this? How can we replace deficiencies? And sometimes, of course, we do therapeutic trials to aid diagnosis, but this is the last step. First we should try curing a disease than controlling. And if we can combine two or more outcomes with one drug, that is the something which is required. So and the treatment, you come to treatment selection, it is not there can be more than one treatment options. It could be a medical treatment, it could be a surgical treatment. Amongst the medical, it is not only that always a patient would require a pharmacological treatment. You may just treat the patient with a non pharmacological therapies as well. For example, if you just talk about arthritis, once in the old age, the arthritis, this pain, stiffness is going to increase, progress further. So for how long can you ask the patient to take these painkillers around the clock? So there are many things which will help in mobilization, reassurance, analgesia, physiotherapy, non-steroidal anti-inflammatory, disease modifying. So as the disease progresses, you may opt for different treatment choices. But we need to be looking at exercise, physiotherapy. This could be initial treatment for many of these patients. Then similarly, what happens is, last time I talked about the prescribing cascade. How a drug keeps on getting added to your regimen, because more or less this kind of prescription is symptomatic prescription. A patient you started a drug for treatment, and then patient had a side effect. Then now to treat this side effect, you add another drug, and then yet another side effect will be there, yet another drug will be added, and that's how excessive polypharmacy takes place. So we need to be monitoring this, reevaluate whether our treatment is working or not. Are there any other alternatives available? Can we withdraw it? Can we stop it? PPI is one example. Most of us think that PPI are harmless medicines. No, they are not harmless. There are reports coming, there are more chances of getting clostridial difficile infection with this, and adverse events will be more if this. And many factors influence the drug selection part, pharmacokinetic part, different formulation I just now discussed with you. Then once daily dosing is convenient and encourages adherence, so try and choose options. But we need to be balancing this with other criteria as well. So other things that you will consider, which can influence inter-individual variability, are specificity, whether they are reaching the site, whether they are metabolized in the liver, like that. Are there any drug interactions? Similarly, the what is the gap difference between the safe dose and the toxic dose. There are many drugs with a low therapeutic index. In my hospital, we deal with all these low therapeutic index anti-epileptic drugs, lithium. They have a very low, and then some require complex monitoring. So this can also affect cost and patient timing. So that will influence whether you would like to go for a warfarin or an aspirin. So, and also there are many patient related factors that can influence drug selection and adherence. Previous reactions, previous response, vulnerability to adverse effect, which depends on the organ function, then physiological reserve. So, and then we must understand, I'll come to this when I'm talking about the elderly here. And then of course the prescribers factors influencing drugs. Familiarity is something which is a predominant factor. If you are familiar with a medicine, it increases the chance of good outcomes. But if you are not familiar, if you don't know what is the dose, what is the maximum dose, how the dose should be escalated, when should you de-escalate or stop, all these familiarity is required. And if there is an ease of follow-up, of course it will help you in the dose titration, and it will help the outcome. So now let's get to the special situations. uh, you know as I said, children are not small. You can see, they are neonates in the first month, up to 1 year, infant 1 to 5 years, because they are different, because their organs are at different stages of development. Their physiological factors, the pharmacokinetics would change according to the weight and the maturity of these organs. So never think that children are small adults. I think if you get this right, lot of problems will automatically. And dose in children should always be calculated with care, because if you look at most of the doses, these are per kg body weight. So with a small difference in the body weight, there would be a change, and these children can be at risk of side effects, if particularly when they have inefficient kidney or a liver mechanisms. So be careful about the age, unless specified. Also, there is a lot of conundrum about what should be the age. Different people take, some take 18 years, some take 14 years, but generally, by and large, I think in India, 12 years or younger are considered as children. So because the dose varies according to the body weight, and therefore it is very, very important for us to state the strength of the capsule or a tablet. If you recall, in one of the session earlier, we discussed the overdose toxicity caused by the iron preparation tonoferon. Just because the doctor did not know the strength of the formulation, inadvertently that child was overdosed. you know Many of us believe that all strengths are similar. No, there are several different formulations of a drug. Particularly, if you look at, just go back and see paracetamol, this iron preparation. There are many more strengths which are available in the market. So always write the strength, particularly when you are writing it for a child here. So this can be calculated based on the body surface area. I think we have internet now. All of us are carrying smartphones with us. If you go on the internet, I found this pediatric dose calculator. It can help you calculating by weight, by body surface area, by Young's rule, by Clark's rule, and this will make use of these gadgets for calculating whenever you are in doubt. Then other things that you must keep in mind, young children may require a higher dose per kg than adults because of their higher metabolic rate. So do consider that. And sometimes, if you are have a obese child with you, and if you simply go by the body weight here, it may exceed the adult dose. So but we don't exceed the adult dose here. So this should be calculated from the ideal weight related to height and age. So just don't go blindly by the body weight. If it is a obese child, you do not exceed the adult dose, and or go by the ideal weight for this child. Then frequency, how do you do this? Generally, just keep in mind, antibacterials, if you look at their dosage frequency, they are given on at regular intervals. When we say regular intervals, it says always 6 hourly, 8 hourly, 12 hourly, 24 hourly. Antibiotics are not prescribed as BD, TD, or OD, because we want to give it at a regular interval, so that effectively germs are killed by this. But keeping this in mind, we have to maintain a regular interval. The nurses have to make a schedule for this, so that they don't wake up the child in the middle of the night for a dose of a medicine. you know uh, you may have to do some adjustment here, give some flexibility, especially when you are dealing with the child. And then where new or potentially toxic drugs are used, carefully follow the manufacturer's recommended dose. Now, which dosage form should you be, liquid or injectables? both of them have their own issues, advantages involved with this. Children generally don't like injections, so avoid as much as possible. But also, at the same time, many of us think if it is a child, they will not be able to take oral solid dose forms. This may be wrong, so parents are the right people. They can help you in selecting a formulation. Many children, even 7 8 6 7 8 child, may prefer a solid dose form, so must explore that. Just don't go by that. Then another thing, when you are giving medicines to children, just because children may not like the smell or the taste of the medicine, they may not take it. So what we do is that we mix with the feed or the other liquid or other meals. Do not do that, because if the child does not take the entire meal, again the dose will be, and also there may be some interaction, drug interaction, drug food interaction that may take place with the food that you are mixing. So be careful about this. And I already talked about this: never use these household spoons. Use these calibrated dropper oral syringes whenever you require. Then children, usually whatever medicines that we use, most of them are not tested in children. They are tested in adults, but because children also may have the same problem, we need to use these medicines in children as well. So be careful, be watchful of the adverse drug reactions, because you are the only source of information regarding adverse drug reactions in children. Reporting in pharmacovigilance program will help. Then we need to be educating patients for safety of the toddlers. Many a times we tell, to AEC, to encourage the child to take the dose. वो कहते हैं कि ये candy है. Never say that this is a candy, otherwise, because they are very curious, they may just catch get to the medicines and may poison themselves. So them all these should be educated to the patients as well. Now, coming to drug use in elderly, this is another, usually the problem is that they have multiple comorbidities. They have complex chronic conditions, and they are often on polypharmacy. So therefore they are at most risk of adverse drug events. And adverse events which are preventable are depression, constipation, falls, immobility, confusion, and hip fracture. All these may be happening because they have been receiving inappropriate medicines for their age group. So in this study, they found that 30% of the hospital admissions were linked with the drug related problems or side effects of these problems, and 35% of these were ambulatory, in OPD, had this adverse event. So this increases the cost of healthcare services and harm to the elderly. Now, excessive polypharmacy, this is a cascading effect. Again, they are on polypharmacy, they have more adverse events, and because of this they tend to receive inappropriate medicines. So we need to be breaking down this cycle. Now, in elderly, you must understand, these people become dissimilar as they age. It's not like they don't exactly behave like adults, and each elderly person would be dissimilar as they age, depending on the compensatory mechanisms they have, the disease severity they have, and there is a fine balance difference between symptomatic and asymptomatic patients. There is a physiological decline in function at the age of 60, and then there is further decline in function, kidney function, from 80% to 70. So as the decade keep on adding, you can predict a fall in the physiological kidney function, cardiac function, and the breathing function. So there are many issues which need special needs. These may be because of the biological needs that I told you, it could be physical, social, or economical. So we need to be, biological. When we talk about the biological dimension, homeostenosis, that is decline in stress resistance and resilience with age, is very common. And this is often becomes atypical in elderly more than 70 years. They may not present with typical symptoms. A small mild symptom may become a severe one, and then because this is happening because of the different organ systems, compromise or with the pre-existing illness. For example, hyperthyroidism may present with atrial fibrillation, confusion, depression, syncope, like that. There are several. Mild hyperparathyroidism may present as heart failure. Mild prostatic enlargement may present as a urinary retention. Mild you find a mild glucose intolerance, and the patient may go into coma. This is all because of the decline in the physiological reserve, and they develop symptoms at an earlier stage of the disease. So even if you see a fever in elderly, there may small improvements may yield dramatic benefits here. Fever is the moment fever improves, their alertness level changes. Correction in the electrolyte imbalance, hyponatremia, there would be a dramatic control of UTI. You again see a dramatic effect there, and it will improve the delirium, dementia, incontinence, all these things. Now, some of the abnormal findings are common in bacteria. You may find premature complexes are there, bone marrow density is poor here, impaired glucose tolerance would be seen, uninhibited bladder so this may be an in incidental finding, and it may not reflect the disease. So don't go on treating everything that you find in elderly as well. So you need to strike a balance. Then because there is a physiological change is happening, so the pharmacokinetics of the drug would also differ in elderly. For example, fat soluble drugs will have longer half life in elderly, whereas water soluble are more concentrated. So you need to watch out for all these things in elderly patient. So the metabolizing enzyme activity may be reduced, hepatic flow may be reduced. So there are that means they are accumulating these medicines in their blood. So once they are accumulating, because there is a reduced clearance from the body, there are 2-3 times more chances of getting an ADR in elderly. So even the pharmacodynamics may change in elderly. They are more sensitive to some of the drugs like opioids, benzodiazepines, antipsychotics, antiparkinsonians, or they may be at the same time less sensitive to beta adrenergic agonist here. So altered drug responses you will see in there are higher chances of drug interactions and adverse effects with these medicines. Then physical dimensions are also important. Falls that we see very commonly in elderly, difficulty in driving may occur because of it could be because of the reduced vision, cataract may be hindering. So better look into other aspects as well. And then decreased accommodation and increased susceptibility to glare, or decreased hearing. So because of these also there may be problems. So look into the physical dimensions as well. And then weak elderly patient may have difficulty in swallowing tablets, so maybe a liquid formulation would be a better. And when in the hospital, maybe you can identify these patients who are at risk of having falls. Maybe you can give a band to them so that people can identify them properly. Then there are social dimensions. There could be disease related symptoms. They may be forgetful, or there may be behavior changes, depression, or they may be having high blood pressure. So keep these things in mind when you are prescribing for elderly. They may be staying alone, there's no one to remind them, they are forgetful, the compliance may go down. There may be lack of family or a social support, there is no one to buy or get a refill for their prescription. So you need to be looking into all these things and look for the shortest duration possible, and if there are any adverse drug reactions, those need to be identified and treated accordingly. So always assess the necessity of a drug, whether it is really needed. Try non-drug treatment as much as possible and prevent falls and fractures. And this prevention of falls and fracture not only requires that you need to increase their bone mineral density, but this can be prevented by, this is very important, improving balance, where because they don't have a good balance, so fall maybe because of, then look into drugs which cause orthostatic hypotension in this. So remove adverse medications from this, remove environmental hazards at home, leveling in the household, tripping, wires, loose wires should not be there. Patients should be encouraged to do exercises, strengthening of legs, and better vision and hearing. This one last is this one is very important. Medication reconciliation must obtain, because these are the people who are on multiple drugs because of the multiple comorbidities. So they may be taking prescription drugs, non-prescription drugs, over the counter herbal medications. So there may be food drug, and which can give rise to adverse drug reactions in elderly. So at least do this regularly. This reconciliation should be done regularly. Start with a smaller dose, gradually increase, and make these regimen schedule simple with minimum number of, elderly are very peculiar in that sense. They will count the number of pills, so be careful about this. And review and check dosage modification. Even when a dosage, they usually identify medicines by color or shape, so if there is a change in the brand, change in the color, packaging, they get confused. So it's good to review regularly with medication so that they are continuing. And if those with the vision problem, hearing problem, ask them to come along with their family members, so that you can involve them and explain to them. In one of the dispensary I went, he says, मैं इसको इतनी बार से समझा रहा हूँ, इसको ना तो कुछ दिखता है ना कुछ सुनता है, और ये दवाई कैसे लेगा. तो I said, have you ever called his family members? तो नहीं, वो तो नहीं बुलाया मैंने कभी. So sometimes unless this is obvious, but unless you tell them, they will not understand this. So if the family member is available, involve them in the care. And then do consider, these people are dependent also. So procurement of medicines may be a problem. So out of pocket expenditure, try and limit this. So always look at what you are prescribing, and de-prescribing is also very important. I think in one line I can say this: one of the first duties of the physician is to educate the masses not to take medicine, inappropriate one. When you need it, of course you need to do this. So Sir William Osler is the father of pharmacology. So I think this is in one sentence he has said many things here. So you can attempt prescribing, of course, but check the adherence and which one can be stopped. And when you are prescribing, selecting a medicine, there are various screening tools available which will tell you which one is a potentially inappropriate medication for elderly. For example, Beer's criteria is one. Then there is a stop criteria, start criteria. In the stop criteria, they have potentially inappropriate prescriptions. So some of the drugs can give rise to adverse, more pronounced adverse effects in elderly. So whereas there are certain indications that these patients should be put on, for example, fiber supplement are better for elderly, but if you give this one Sina and Bisacodyl, they may have intestinal obstruction. So look into this. All these things, tools are available on the internet, and all of us have now access to internet. Maybe once we know what to look for, you can go and check. There are many such medications which should be considered for stopping. Many patients have dependent ankle edema. So, but furosemide, loop diuretic, is not a choice for them. Perhaps then you have to look for other drugs for this, but not a furosemide. Otherwise, these patient will get into trouble. So, like this, there are many drugs. These are all on the internet. You just look for it, you will find it. So, I think answer to many of these things, what I had been saying, children, elderly, the pharmacokinetic dynamics, the inappropriate, all these things are taken care in the standard treatment guidelines. So these are the disease oriented manuals. They focus on treatment part, but the STG will help you if you have made a diagnosis, because then the further treatment, you need not worry about all these factors that I had been talking about this. But if the diagnosis is correct, the outcomes will also be better, and it reflects a good consensus. Nowadays, if you look at the legal position of standard treatment guideline, of course the name is guidelines, so it is not mandatory for you to follow, but at the same time, but if you deviate from these guidelines, one can get into trouble, because of the societal changes that has happened over the years. Litigation rate has risen, the violence case against the doctors have risen. Most of the time, if you get to the root, you'll find, perhaps there was some communication problem, or perhaps the doctor gets into trouble because the standard treatment guidelines was not followed. This is a recent news. I didn't get the date here. Maybe I can put 3 doctors were banned from private practice for not following the standard treatment guideline. So if you are not following a standard of care, you should have good reasons why is this standard guidance not applicable on this patient. This was in Jammu and Kashmir, and this is a recent report that we got. So there may be difference of opinion amongst ourselves, but there should not be any inappropriate variation. Whenever you try and find out whether a standard recommendation can be applied to this patient or not. If not, yes, you are free to use your clinical judgment here, but you should have enough logic here to explain to that, because the law does not expect you to be a meritorious person. They expect a general standard of care here, and they also expect that the doctor, whosoever is treating, is able to monitor adherence to these protocols as well. So some of these features, we have NHSRC has produced 14 standard treatment guidelines. Now ICMR has come up with the 100 pathways for this. Recently, they have also come up with the infectious syndrome based approach for management of infectious diseases. You can consult any one of these. This is one of the publication that we had for last 20 years. So it's a ready reckoner type of guidance. It tells you how do you step up therapy, how do you step down, and then gives the algorithmic approach is based on evidence. And a lot of people have contributed in developing and revising. We've been doing this every 2 to 3 years. So this is the 6th edition. We have in between various Indian states also adopted these guidelines. And also, the one of the feature is, as I was telling you, treatment always gives the non pharmacological. We start with that, because no point in treating a patient of hypertension or diabetes if he continues, no diet control is there. So pharmacological treatment, how and which one will you choose, how do you assess the response, then patient education is there. This is one of the unique features of this book, and this is the most challenging task as well, because unless you engage to patients in the treatment outcomes will not be favorable. So but many times we want to engage them, but we don't know what to tell, because there are so many adverse drug reactions, there are so many do's and don'ts, and we are always short of time because of the heavy patient workloads. So this section provides you, what are the key messages that we want to get across to the patients here. And of course this is backed by the evidence. Drugs have been selected by using these four criteria: efficacy, safety, cost, and suitability. And as I said, patients, without patients, no treatment can be complete, and this is part of it. And I hope after the session today you'll be disseminating and reinforcing this concept, encouraging people to adopt this, and we can close the gaps between the knowledge, practice variation. Many of you are quality managers here. You are struggling to implement NQAS standards, say that whether the standard treatment guidelines are followed or not. You are struggling to do that. Patient safety issues, of course, are there. So you can always plug these gaps here, and with standard treatment guideline, and it will help you ensuring adhering to laws, requirements, rules, standards as well. They are all very supportive. I know of many cases where people got exonerated, बिकॉज आजकल मेडिकल नेग्लिजेंस के नाम पे बहुत सारा डॉक्टरों के ऊपर प्रेशर रहता है, तो दे गॉट exonerated because they established in the court that they were following standard guidance on this. So I will always encourage, motivate you to follow standard guidance. Yes, of course, if the patient's requirement are different, you are free to do it, but have enough logic for doing that. I think I'll stop here. Next session is on 18th February. Same time, we'll see here. I will stop this. Uh, Now, Annapurna, we can.
Okay, ma'am.
I
Thank you,
think
ma'am.
I exceeded 10 minutes. Sorry, doctors. And, but I think the
Okay, ma'am. Fine. Thank you, ma'am, for sharing your valuable knowledge on the safety prescription for child and elderly people. Now, I welcome Dr. Professor Narendra Pal Singh, Dean Researcher of Eternal University, Himachal Pradesh, and he is also a former Director Professor of Lok Nayak Hospital from New Delhi. He is a member of Global Disease Burden Program and also a NBE National Coordinator for DNB General Medicine. He's also received award from State Award by the Delhi government in 2007, IMA National President Appreciation Award and IMA Meda Achievers in 2014, Double Helical National Health Award from 2017, Max CEO Award in 2017, and ADPA Excellence Award in 2018. He has also more than 150 publications in national and international journals. I welcome you for this session, sir. I request you to take the next session on diabetes mellitus. Over to you, sir.
Thank you, Annapurna, and let me at the outset thank and appreciate Dr. Sangeeta's effort in trying to disseminate this knowledge of rational drug abuse. And I've been observing her for the last 3 decades, and her passion to create this awareness is not reduced. In fact, I strongly believe that she deserves a place in the awards which are being announced very soon on 25th of January. So I'm very sure at one day, if I have to contribute, I'll definitely put her name. And I'm blessed to have been listening to her for last 2 hours, and her passion to speak is immense. And there's something known as listeners fatigue, but I could hardly see anyone leaving or in the audience. The attendance remained the same. In fact, increase significantly. So thank you, Professor Srivastav, for giving me this chance. And I would love to be a part of any one of you in any future whenever there is a need. And is it possible for you to see my slides?
Yes, sir.
Can you see the slides?
Yes, sir.
Yes.
Yes, sir.
Okay.
Visible, sir.
So what the mandate Sangeeta gave me was to talk about management of diabetes mellitus. What are the current concepts and guidelines? We all know that now diabetes is a part and parcel of India and the world, and as was pointed out by the earlier orator, that we are now the capital of diabetes, and we are going to be the largest population on this earth for any country. And uh, guidelines on guidelines have come up in last several decades, and people have now recognized and realized that diabetes mellitus is not a disease per se. It affects the human mankind, it affects the human person in each and every part of the body. So the focus now is not on treating diabetes per se, but on trying to manage the associated risk factors, the cardiovascular complications, and also the other complications which these patients do have. And recently, RSSDI has come out with their own guidelines, and so is true about American Society of Endocrinology, which come out with their guidelines every year. As was pointed out by Professor Sangeeta also, that we are not aware what is happening to us because we don't reach the populace, the doctors. So 53% of the populations actually live without being diagnosed for diabetes. So that is very important. So if we have 100 cases of diabetes, half of them remain undiagnosed. There is a significantly higher prevalence of cardiovascular disease and other complications amongst type 2 diabetes. And there is a need now to develop a pragmatic, cost-effective strategies, which has been discussed in the standard treatment guidelines, which should not only have facilities and strategies for screening, primary, secondary, and tertiary prevention also, so that it reduces the substantial cost to the society. And the landmark trials in India have shown that lifestyle modification continues to remain one of the very, very important tools to prevent and manage type 2 diabetes. Now, I just want you to understand that the term diabetes mellitus is a metabolic disorder. Now, it has multiple etiology. The only part which we discuss is what was known as hyperglycemia, which remains for a long time. So it talks about disturbance of all three: carbohydrate, fat, protein metabolism, which results from either there is a decrease in the insulin secretion, there is decrease in the insulin action, or both. And now we know that there are so many other factors which are involved in trying to induce diabetes, which more important is it affects include a long-term damage, dysfunction, and resulting ultimately in failure of organs. We know 50% of the patients undergoing hemodialysis in our country all over the world have an underlying diabetes as the cause. So what is the magnitude of the problem? Now, these are two elegant studies which have been done. This is an ICMR sponsored study which is done across almost 15 states, and what you can see from here is that both in urban, rural, men and women, the prevalence keeps on increasing as we age. So this is basically an aging disease. Now, what is starting from 5% or 3% in the age curve of second decade gradually goes on to have almost to the tune of 40-50%. So overall, the prevalence of diabetes was found to be 7.3 to 10%. But I feel that this number is also an underestimate. The prevalence actually could be much higher. And this has increased from 4 decades earlier. When I was a student in MAMC, the incidence used to be told to us as 2%. So definitely, despite of our best efforts, despite of our best affluence and economic development, is associated with increased prevalence of diabetes. And this is another study from south part of our country where they have looked at decade of prevalence among both rural and urban population. So here again in 2006 to 2016, both the prevalence of pre-diabetes as well as the diabetes among city, among peri-urban and among rural area has shown an increase. So this has, as you can see, from 18% to 21% in the city, 16 to 20% in the towns, and also even the peri-urban villages, the prevalence has increased. So there is a significant issue related to that. Now, how do we actually classify diabetes? This again has changed a lot. Now we have this recent classification which talks about type 1 diabetes, which we know occurs in younger individuals, is characterized by insulinopenia and presents with ketoacidosis. Type 2 diabetes is what is most prevalent. More than 90% of the patients have type 2 diabetes. Is my voice audible, Sangeeta? I think.
Yes, I can
Yeah.
see here, and no problem. Maybe the person who is having problem can
Yeah.
log out and log in again. If you
Okay.
have a
Okay.
problem.
So what is important apart from these two diabetes types are hybrid form of diabetes. We have now slow evolving immune mediated diabetes in adults, what was earlier known as LADA. The name has been changed to this. And similarly, ketosis prone type 2 diabetes, which was earlier known as flatbush diabetes. Similarly, we have what was earlier known as MODI or the monogenic form of diabetes. We have diabetes when somehow or other the pancreas get affected. We have due to endocrinopathies. This is becoming very common, especially after COVID. We have seen steroid-induced diabetes. Now this is again classified as other specific type. Similarly, infections can precipitate diabetes. And so there is a fifth type which has been described as unclassified diabetes, which is a temporary category when the diabetes does not fit into that. And also what was known as gestational diabetes is also now known as hyperglycemia first detected in pregnancy. It could be both diabetes mellitus in pregnancy or it could be classified into gestational. Now, how does it impact the organ system? And as we can see from this very, very busy slide, the type 2 diabetes in fact involves each and every part of our body. What is now known as a very, very important contributor to the long-term morbidity and mortality is sarcopenia. So the diabetes, chronic diabetes would replace muscles with fat in the skeletal muscle, will cause gut alterations in the digestive system, will cause increased risk of fracture among the bone, will cause some more propensity for skin infections, will cause one of the very, very important dreadful disease now which we are facing is NASH. It can also impact the brain and can cause premature aging. It can impact the adipose tissue and cause inflammation among the fat, which is again a very, very important entity to cause NASH. It can impact our immune system, and no doubt that it is one of the major complications which occur are due to diabetes are because of the cardiovascular as well as the renal problem. So, in effect, diabetes impacts almost each and every organ of the body. That is why there is a need for us to understand our patient, individualize the treatment, and treat the patient holistically rather than treating diabetes per se. So my effort in next half an hour would be to try and take you through the overall management of diabetes and the person who's suffering from diabetes. So how do we diagnose it? We all know very well, but more important is first is the criteria for screening. Who should be screened? Well, we know any person who's more than 35 years age should have the testing done, but more than that, if a person is obese, if his BMI is more than 25 and he's got a high risk ethnicity, and in Asian Americans are one of the history of cardiovascular disease, a person who's got a hypertension, a person with a lady with the polycystic ovarian syndrome, physical inactivity, and other clinical conditions of insulin resistance are the candidates where the blood sugar should be checked. Similarly, a person who has pre-diabetes, the blood sugar be checked yearly. A person who are diagnosed with GTM, we must do their blood sugar lifelong every 3 years. For all of us, after 35 years of age, we must get our blood sugars tested, and if they are normal, then we must repeat it every 3 years. Of course, person with HIV and AIDS should have their blood sugars tested. And how do we define pre-diabetic status? It can be either an impaired fasting glucose when your blood sugars range between 100 to 125 milligram, which is a fasting, 12 hours fasting, or we call them as impaired glucose tolerance if the person's 2 hour post-conjoined, she talked about 2 hours importance, where the blood sugars are between 140 or 199, or if the HbA1c tested is 5.7% to 6.4%. So anyone who has a blood sugar fasting of less than 100, of 12 2 hours less than 140, and an HbA1c of less than 5.7 is considered as normal. And these are the values when you are considered as having pre-diabetic state. And finally, if the person's fasting blood sugar is more than 126, or the postprandial is 200, when you take a 7.75 grams glucose, and the fasting state should be at least 8 hours, or if the HbA1c is more than 6.5%, or any random sugar whose blood sugar is more than 200 and the patient has symptoms, are diagnosed as having diabetes. So there are clear-cut diagnostic criteria of defining diabetes. What is important is to realize that is HbA1c a very, very reliable indicator? When you have a marked discordance between the measured A1C and the plasma glucose level, you should suspect there's something wrong with the HbA1c. Because with the way we test it, it is basically a glycosylated hemoglobin which we are testing, and it can get impacted due to presence of hemoglobinopathy like sickle cell disease, pregnancy, especially in the second, third trimester, G6PD deficiency, patients in HIV, patients who are on hemodialysis, or patients who had a recent blood transfusion or on erythropoietin therapy. There, in these situations, we should rely more on blood plasma glucose than HbA1c. Otherwise, HbA1c is a very good tool to detect diabetes. Also, more important is now the role of a self-monitoring glucose. We should actually perform it with a reliable standardized glucometer. Now the facilities even in India are available of continuous glucose monitoring, and this is one such device you can see, and the person can read the blood sugars and monitor, and it is especially so important in patients with type 1 diabetes or those who have brittle diabetes. However, they are, of course, cost is a concern, but this device costs around 4,000 rupees, and we need the same amount for the monitoring. Then there are the other substances which can interfere with glucose that we need to know that before we actually call a person as diabetes. More importantly, how frequently should we be doing blood sugar monitoring? We should do an initial frequency scheme, who are recently diagnosed or whose management of diabetes is through the lifestyle changes. This should be done every month, 2 monthly, or staggered daily self-monitoring if your HbA1c is high and if you are on an insulin treatment. Similarly, staggered daily self-monitoring if you are on a non-insulin pharmacological management, and the same is true of patients who are using insulin permanently. So the idea is that you should understand or teach the students, the ordinary persons, about how to self-monitor your glucose. Now, having talked about the epidemiology and the diagnosis, my next focus is trying to prevent or delay the onset of type 2 diabetes. Now, it is very important that we monitor for development of diabetes in those who have pre-diabetes, for at least annually, based on the risk and benefit assessment. So a person whose blood sugar is between 100 and 120, don't leave them alone. Don't tell them that you don't have diabetes, don't worry. No, we must try to monitor them regularly. We should seriously talk to people who are overweight and obese, and wherever I go, whether it's in a social function or whether I'm talking to someone, whether they are my students, if I find a person who's overweight and obese, I spend 5 minutes and trying to empower him about how his weight reduction can actually have a great impact on the reduction of your blood sugar. 120 minutes of moderate intensity physical activity is what is required. People have done prevalent studies on physical activity versus medication therapy. This is free. 150 minutes per week of a brisk physical activity will, in this, whether you can even walk in the afternoon. What I suggest to my patients is 10,000 steps per day. And now we have these apps available where we can download. And if you are able to do your 10,000 steps per day and 3 lakh steps per month, then your chances of getting diabetes will be much less. Of course, we need to evolve. Like nowadays there's a fashion of so-called intermittent fasting and other things. But more important is to say the quality of food and the quantity which you eat are very important. There's been some studies which have shown a metformin therapy may also help you preventing diabetes. More important than preventing diabetes is preventing the vascular complications. So now we have availability of statins which have been shown to not only increase the risk of type 2 diabetes, but also they are modified risk factor for cardiovascular as well as neurological complications. So we need to understand, we need to see how we can prevent vascular disease in patients with diabetes mellitus. So these are the recent guidelines which have come up somewhere in October, November. So my next set of slides are based on clinical recommendations for management of type 2 diabetes by RSSDI and also by the American Society of Endocrinology. So we need to have a treatment plan. We just can't write prescription like this. We need to assess the risk of diabetes complications in them, see if they have atherosclerotic cardiovascular disease, if they have a CKD, which try to stage them. Also look for hypoglycemia risk, assess for two dreadful complications of retinopathy and neuropathy. Also goal setting. We need to understand that this is a chronic long-term disease. We have to tell them how we can keep our goals of HbA1c and blood sugar and time in range target. If the blood pressure is also present, then we have to establish the blood pressure targets and we have to talk to them about diabetes self-management goals. In addition, the third step is only the therapeutic treatment plan. So each and every step is equally important. We only resort to what is known as this part, pharmacological therapy. But each and every step is equally important in a patient who has diabetes. So lifestyle management, a medical nutrition therapy, a pharmacological therapy for cardiovascular renal risk, and then finally glucose monitoring and insulin devices and referral are part and parcel of the therapeutic management strategies which we do. So what are goal settings? Now goal settings has been individualized now. You can't have a same goal setting for a young, energetic 30-year or 40-year-old male versus an elderly person who's got various complications. So the goal setting also is now individualized. It can be as strict as uh, less than 7% in patients who have a less chances of a side effects, who's newly diagnosed, whose life expectancy is longer, who has no comorbidities, who does not have a vascular complication, and who's highly motivated, adherent, and is readily available. That is, finances are available. To the patients who have complications, who are elderly, as Sangeeta has talked about polypharmacy in elderlies, who have various complications and who are non-adherent. So there's no point in keeping a very strict target of less than 7% in them and not following their tasks. So we can be less stringent with them and assess glycemic status as I said 2 times a year. So HbA1c can be done twice a year and also assess glycemic status at least quarterly as and when needed when those who have not met the glycemic controls. So what are these lifestyle modification? I think an important thing which I personally believe is this exercise. All three types of exercises, isometric, isotonic, and yogic exercises can help actually us in not only reducing our pill burden, but also sometimes in stopping our pills. There have been evidences and there's been demonstration every day in the media about how yoga can actually help you not only prevent but also manage diabetes mellitus. I will not say more than that. You can look at the literature for that. But as I said, 150 minutes per week, more than 30 minutes of moderate intensity aerobic activity. You can do swimming, you can do cycling, you can do walking. Also, try to get up. Now, the problem with this online is that we keep on sitting at a place for a long time. But even during your work, at your workstation, you can keep on getting up and do your work. You can do some muscle strengthening exercises. And I mentioned 5,000, but I personally feel that 10,000 steps is doable. And there are a lot of yogic practices which we have talked about. So the principles of nutritional therapy is to achieve and maintain, Sangeeta, please listen, achieve and maintain a good body weight goals. We should also attain individualized glycemic, blood pressure, and lipid goals. And also, we should try to prevent and complications of diabetes. This is what the so we should promote and support healthful eating patterns, emphasize a variety of nutrition dense foods. And what are these? Very, very busy slide. But what is important is for us to understand when we say carbohydrate, we should emphasize nutrition dense carbohydrate sources that are high in fibers. Something like non-starchy vegetables, fruits, legumes, whole grains. Nowadays, there's a need for us to take multigrain atta. Gone are the days when we used to eat that white atta. Now we always eat a brown atta. People with diabetes are advised to replace sugar-sweetened beverages with low calories, no calories beverages. So juices are out now, cold drinks are out. This so-called this nariyal pani is in now. So we do you drink a lot of nariyal pani nowadays. So we also have to understand that when we are using insulin, we should tailor our dietary therapy based on our insulin requirement. Protein, again, a very, very important thing. We need to understand that protein appears to increase your insulin response. Similarly, dietary fat, we need to know that what is the evidence why we should be not eating a monosaturated food or a saturated food, and how much amount is also, it is beyond the purview of this lecture to tell you in detail. But more important is that we need to understand that alcohol should be stopped or taken in moderation. Sodium, again, a very, very important culprit. In fact, the fact is that now the focus is more on sodium than on sugars and non-nutritious sweetness. So these are some of the components which you have to look at and then include a good dietary therapy. So self-management is extremely important. So our role is not to prescribe medication, but also to educate our patients about self-management programs and support. So because all these are very important goals for diabetes management, so we should critically spend more time with our subjects at least 4 times during the time of a diabetes management. One is at diagnosis, when person is not meeting the treatment targets, when the complicating factors are there, or when transition in life and care occurs. So we need to understand because many of our patients are now long-term follow-up with us. We are family physicians, so we need to keep them, give them some longer time, especially in these 4 times. And finally, after your nutrition therapy and non-pharmacological treatment, what are the pharmacological approaches we have? So this is again a very, very busy slide. We understand that there are now huge medications, number of medications available to treat diabetes, but we need to understand that now the issue is that we need more time. We need more time to understand these medications and also to see which medication is important. We have metformin, which is the sheet anchor of management of type 2 diabetes. We have now SGLT2 inhibitors available. You can see these red points of all these three agents, oral GLP-1, semaglutide. These three agents have been found not only to have various impact on HbA1c, but also to reduce cardiovascular events. That is why these drugs are now being hyped so much that now almost all the guidelines mention SGLT2 inhibitors as the second line drug. The renal and the cardiovascular benefits are immense with these two drugs, and cost is of course a factor, but the cost is also coming down. Most of the CGHS dispensaries have now this drug available, and which is being, the generic forms are being available. Overall, these are the three group of drugs which are given 4 plus 3 plus indications. Of course, we have our time tested sulfonylurea, which is one of the best drugs to control our blood sugars. However, the issue is that of a weight gain. There are more chances of hypoglycemia with this. It is MACE neutral. Similarly, magletides are good drugs in certain individuals. Thiazolidinediones cause weight gain to the tune of 4 to 5 kilograms. So obviously, this drug, though very good in decreasing insulin resistance, but on the other hand causes edema and obesity. So our DPP4 inhibitors are weight neutral and they are again one of the very good drugs which can be prescribed in various conditions as well. They do not cause hypoglycemia. Similarly, alpha glucoside inhibitors are also available for postprandial hyperglycemia. So after this, I am not going to discuss these drugs individually. So these are some of the characteristics which we look at. We look at hypoglycemia possibilities. So there are certain drugs which cause very high chances of hypoglycemia, which is equally dangerous. Weight gain, these three drugs can cause weight gains. There are MACE or major cardiovascular events. Now these are the ones which can reduce their events, or also alpha-1 glucoside inhibitors. Cost is again a very important factor to treat because it's a long-term illness. Biguanides are very cheap, so is sulfonylureas. But at present, these drugs, which are very effective, are costly. But I'm very sure with Sangeeta's intervention, they will also become cheaper in near future. Metformin remains the first choice. Now, that you must understand. Any person of type 2 diabetes mellitus, the first drug, which unless it is contraindicated, should be the metformin. Of course, one should combine metformin with other drugs like DPP4 inhibitor, sulfonylureas if you want to bring down the HbA1c to significant level. And if the patient suppose is on a very high blood sugars, then we can resort to so-called insulin for some time, short-term insulin. But by and large, the dictum remains that you should start with metformin, and if the patient is not responding, then we can add sulfonylureas or DPP4 inhibitors. What is important is consider each initiation or dose increase for some time. Don't be in a rush. Patient will always say कि मेरा blood sugar control नहीं हुआ. But look at the response for at least 2 to 3 months before you change the dose or before you change the medication. This is very important. It's a lifelong disease. You can't be expecting a person to bring down the blood sugar from 350 to 150 in a day or so. No. Please tell them that we have to be patient. Of course, any patient who has a very highest cardiovascular risk disease or a heart failure or a CKD, every guidelines now recommends SGLT2 inhibitors as the second line or GLP-1 agonist. These are very, very costly drugs. They are not yet, the oral form has been marketed in India, but it is still a very costly. But this drug has become much cheaper because of the availability of now generic medications. Of course, if you want a weight loss, then GLP-1 agonist is one of the good drug. We know there are two types of injectable. One is insulins, our old age friend, and GLP-1, which has come regularly. We have these different types of insulins. We have NPH, we have Glargine, we have Detamir, we have prefixed, and we have Prendial. These are short-acting insulins, which are human regular, Lispro, Aspart, Flucicline. Inhaled also now is available. We have our basal insulin. So the basic principle remains the same. First thing is always start with the basal dose. Suppose if you have to start the patient on insulin, we have to first target the fasting blood glucose, and that will be targeted by a basal insulin. And what is the dose which we should start? Suppose if the patient is around 50 kilograms, then we should aim to start around 10 to 15 kilograms. In fact, much less than 0.5 units only. So 10 to 15 units or at the most 25 units, and gradually then monitor their blood sugars. If our blood sugar is coming down than normal, then we have to reduce it. If the patient has a high bedtime, then of course we can start with the postprandial glucose. There is importance of trying to educate hypoglycemia and patients who have a high glycemic variability. These are the things where we need to be considered about reducing the basal insulins. So these are three types of insulins, and these are some of the injectables which we have, GLP-1 analogs. These are also available now, and the combination is also available, but they are actually, as of now, only a select group of people who can afford financially are being given these drugs. By and large, for a community, these drugs are still quite far away from the reality. And these are some of the flexibilities which shows we know that if you give multiple dose insulins, they have flexibility, they have low risk of hypoglycemia, we have a higher cost. Similarly, we have various continuous infusion pumps available. They have their own positives and negatives, but I'm not going to spend more time on this because of the fact that it is not still a part of standard of care I'm very sure Sangeeta has also not included them in her standard treatment guidelines. More important is the therapeutic reach. This has been discovered and recommended by RSSDI. This talks about patient-centric approach. Now, this is very important. If the patient has advancing age, then we take a strategy of A. If the patient has a very high BMI, then we take a strategy of B, and so forth. Advancing CKD, the duration of diabetes increase, E is your established cardiovascular agent, F is your financially patient is very poor, and if the patient has a glycemic status which is worsening, or if the patient has chances of high hypoglycemia. So all these individual issues, we have various strategies available. We have the first line available, we have the second line available. So, like I'll give you an example. In the presence of chronic kidney disease, we should avoid drugs which can cause hypoglycemia. We should avoid drugs which can lead to more lethal issues. So, similarly, a person who's obese, we should avoid using pioglitazone, etc. So, this is a sort of a wheel given by RSSDI, which talks about patient-centric approach. So, one shoe will not fit for all. We have to individualize our approaches to manage. Now, this is again a very, very complicated slide, but this is the one which has come recently in 2023 by in the diabetes care, which talks about two things. The first goal, two goals. One is goal of cardio-renal risk reduction, and they talk about person as a whole. They don't talk about diabetes control, but they say we have to reduce the risk of cardiovascular and renal complications. And second is the goal which they talk about achieving and maintaining glycemic and weight management goals. So based on what goal you are trying to address, we have various formulation and combinations available. So if the patient has a significant atherosclerotic risk factors, then they say GLP-1 receptor antagonist will cause you a cardiovascular benefit. Or if the patient has indicator of high risk, then SGLT2 inhibitors can be much more beneficial. However, if the patient has heart failure, then again these drugs have been found to not only address diabetes but also address heart failure. So this drug, one drug, can actually impact two strong indications. Similarly, if the patient has CKD, they say that there are certain very good evidences-based studies to say that SGLT2 inhibitors can reduce your CKD progression. So all this is based on the cardiorenal risk reduction. Then, of course, we have various studies which have shown how can we achieve our goals. So this talks about metformin, this talks about combination and consider avoidance of hypoglycemia in high-risk individuals. Therefore, they talk about various medications which you can give. They talk about general lifestyle. They talk about intensive evidence-based studies. They talk about obesity management by doing a metabolic surgery and weight reduction medications also. And finally, they talk about when you choose a glucose lowering therapies, you talk about how drugs can also cause weight reduction. So we have weight neutral medications, we have drugs which can cause a very high weight loss. So all these have to be considered rather than starting a same form of a medication for each and every individual. So this is a huge change in the management strategies for patients who have presented to us with diabetes mellitus, but are likely to die of complications of cardiovascular and uh, other disorders. So it is important for us not only to manage diabetes, but to assess comorbidities. So hypertension, look for diabetes retinopathy, look for neuropathy, look for diabetic kidney disease, and look whether the patient is likely to have cognitive impairment and stroke or not. So these are some of the targets to treat blood pressure in such patients. We have to reduce the blood pressure to less than 140/90, and if the patient has a proteinuria, then the reduction is much more stringent. And these are guidelines which talks about trying to reduce the blood pressure through this chart. That is, if the blood pressure is more than 140/90 and less than 160, start one agent. And this could be as ACE inhibitors, ARB, or one of these drugs which can be started. But if the blood pressure is high, then start two agents and start two out of the threes. That is ACE inhibitors with calcium channel blockers or ACE inhibitors and diuretics. Or if the patient has albuminuria or CAD, then start ACE inhibitors and or calcium channel blockers or diuretics. So this is the life management for patients who come to with hypertension. And if the targets are not met, then add more third agent. And finally, if these are not met, then add mineralocorticoid. So this is also one of the dictum for the management of patients who have both diabetes and high blood pressure. And of course, these are the two drugs which are being found a special mention about how these drugs, if selected, can now help you in trying to address the cardiovascular and renal reduction issues. So, as far as diabetic kidney disease management is concerned, these are some of the standard guidelines. We've talked about that. We need to ensure that patients should be on ACE inhibitors and ARBs. We have to look at the creatinine rise, monitor them carefully for hyperkalemia. We should continue with SGLT2 inhibitors unless the GFR has gone to less than 25. We should periodically monitor serum creatinine and potassium level. And these three important things: diabetic retinopathy. Every person should be get screened for one every year to two regarding the presence of a diabetic retinopathy. We have to address the patient's condition as a whole. We have to also ensure that an ophthalmologist sees the eye in dilated stage. So sometimes we can do a retinal photography to compare from the baseline, and there are now evidences and medications and procedures available which can address the issue of blindness among diabetes. Similarly, neuropathy requires to be screened. Almost 50% of the patients may be asymptomatic, so there is a need for us to do this annual monofilament testing, which can help us detect diabetic neuropathy in a much better way. And also, we have now recommended management strategies: GABA pins, serotonin inhibitors, tricyclic inhibitors, and sodium channel blockers. And if we are not able to achieve, because symptom control is also extremely important to achieve what is known as better quality of life for such patients. Foot care, again, a most neglected part of the diabetes management. We need to understand we should always do a once in a year at least comprehensive foot evaluation. We inspect the skin, we look for deformities, we do a neurological assessment, we do a vascular assessment, and based on the risk category of ulcer, we need to examine them. We need to either refer them to a specialist who can address the issue of foot care for them. So it is extremely important that this diabetic foot infection should be caught much earlier. It should be managed in a proper way. We should not only give fluid resuscitation, control the metabolic arrangements, we could also cause infection control. All my slides are available. This is an open source, so I request Dr. Sangeeta to kindly share it with them if required. So similarly, renal vascularization and finally debridement may be required. Now, Dr. Sangeeta did talk about two important extremes of age. One important is an elderly person. What should be our strategy for treating diabetes in them? Glucose values have to be maintained at this level. If they are more than high, very high, then we need to talk about the things. But if the person is sick, if the person is vomiting, then we should change our strategy. More important is we have to understand that strict glucose control and blood sugar is not necessarily in end of life care. Don't try to focus on targets in a person who's 80 years of age. Let him enjoy his life. More important is the quality of life managed in such patients. So the treatment goals are different in them. And as I said, if a person is healthy, the treatment goal is less than 7%. If the person has complex issues, it is less than 8%. Very complex issues, avoid reliance on HbA1c. Consider likelihood of benefit versus the complications due to the drug per se. Pregnancy is one such important issue, type 2 diabetes in pregnancy. I'll just say that screen the individual now at 4 to 12 weeks postpartum, and especially if a person has a history of gestational diabetes, we should screen every 3 years. This is a approach. I'll not go into details. It is a one-step strategy. First, we should test with a 75 grams glucose, and we should test fasting 1 hour post 2 hour, and these are the values which will help you make a diagnosis of GDM. Then, if the patient, we can then move on to two-step strategy, where in the first step we give 50 grams, in the second step we give 100 grams, and these are some of the values. You can refer to the management and diagnosis of diabetes in pregnancy to further chapters, I will just sensitize you about how you are able to make a diagnosis. And these are some of the important targets which we need to achieve in such patients. So the third important management or of the complex issue is obesity management. Now again, a very, very important part of diabetes control is the obesity management. We need to again resort to nutrition, physical activity, and behavioral counseling. We may also consider giving the pharmacological therapy if the HbA1c or if the BMI category is very high. And also, we may recommend at least a metabolic surgery which can have a very dramatic impact if the person has type 2 diabetes and a severe obesity. This is now evidence based that metabolic surgery can not only help you control diabetes but can also cure you of type 2 diabetes mellitus apart from reduction of the weight. And these are some of the drugs, Orlistat we know, and we know about certain newer drugs available, but the drugs which are addressing both the issues are the GLP-1 receptor agonist. Again, not only they control your blood sugars, but they can also be very effective tool in reducing your blood in your weight as well. And finally, talking about diabetes and COVID, well, we need to understand that there is a huge risk of cardiovascular morbidity and morbidity among diabetics who had developed COVID, and the complications rate were much higher, especially not only the acute complication, but also the long COVID was also seen in much more among diabetics. So we need to understand the and empower our patients about the importance of COVID in such individuals. And though there are no clear-cut changing instructions on glucose-lowering drugs, but it is important for us to sensitize them. And lastly, regarding immunization, all diabetics should be offered immunization for hepatitis B, HPV, influenza, pneumococcal vaccine, and also flu vaccine every day. So I have just given you the brief about how we should go about managing a diabetes. I understand in a half an hour lecture, it is very difficult to tell you individually about the medication management. But if you apply this principle to your patients, I'm very sure you will be able to manage your patients with diabetes. Sangeeta, I have 2 or 3 case scenarios. If you want, I can discuss it with them.
Sir, sure, sir. Please go ahead. I was
Right.
on mute.
So I just have simple case scenarios if people can answer. The first is a 46-year-old obese businessman. He's obese. His businessman is BMI is very high, 32. He has also high blood pressure and it is of 8 years duration. He has a poor glycemic control, right? He was on a maximum dose of metformin and sulfonylurea, has been following his diet and exercise schedules very strictly. So he's also concerned about his weight and wants advice which class of oral anti-diabetic drug would be best suited in his case, which may provide both an efficacious glycemic control, weight loss, and cardiovascular protection. So any guesses? And he of course would like to know the side effects of these drugs. So
You can write in the chat box, the
yeah,
responses.
so it's a simpler query, but if you have gone through the lecture or otherwise, so obviously, yes, I agree with Sanjeev. The class of drug which can be given, see, the patient has already gone metformin full dose. So the class of drug which is now available, which can address all his issues are SGLT2 inhibitors. They are not only efficacious, but also can cause weight loss, and also they will have benefit on the blood pressure control and cardiovascular protection. So after metformin, the drug which you should choose is SGLT2 inhibitors. However, we have to empower our patients about the issue of urinary tract infection, and also there are certain issues with them about non-ketotic, non-hyperglycemic ketoacidosis. So SGLT2 inhibitors are good drug, but normoglycemic ketoacidosis is an issue which we need to look at. Similarly, we have an elderly gentleman. He was diagnosed type 4 diabetes 4 years back. He's on maximum tolerated dose of metformin. So all these patients have to be started on metformin. Her glycemic control has not been well for last several weeks, and we need to add one more drug. The only other comorbidity she has is osteoporosis. Now again, you have to look at the comorbidities. before adding the second drug, we have to ensure that we don't add a drug which can worsen his comorbidities. She's had a high fragility fracture also and is taking calcium and vitamin D. She's lean, frail looking. So what is the best drug for her? So any answers? Insulin. Good. So again, as I said, the patient has severe osteoporosis. Among the available drugs with low hypoglycemic propensities are metformin, pioglitazone, and SGLT2 inhibitors. But both these drugs, one of their long-term effect is that they have been shown to worsen osteoporosis. So, in such a case, sulfonylureas are potential, but they can cause hypoglycemia. So, the ideal drugs for them, for this elderly lady, because we don't want to rush to insulin, the patient may not be ready to accept insulin, and on the other hand, it can cause again hypoglycemia. So, the ideal drug for her would be a DTP4 inhibitor, which is reduces her blood sugars, HbA1c, without being impacting on weight and also without causing hypoglycemia. So the last case is again a young female as compared to the previous one. She has a type 2 diabetes of 12 years. Her GFR is 50 ml. She is in stage 3 CKD. She is on glimepiride 3 milligrams per day. But this is a drug which is a long acting drug which has a propensity to cause hypoglycemia, especially in the presence of CKD. Her HbA1c is 6.7%. She has a mild retinopathy and she had a history of recurrent urinary tract infection in the past. So, which class of drug would be better suited for her? So, she has CKD now. So, we need to understand sulfonylurea, especially this long duration sulfonylureas, can cause significant hypoglycemia. So we have short-acting hypoglycemic agents like repaglinide. We have sulfonylureas, which are short-acting glycoside and glipizide. They can be used. We also have, as you have rightly mentioned, we have DPP4 inhibitors, sitagliptin. They might require a dose reduction, but they are very neutral drugs, very effective drugs, don't cause hypoglycemia. And in this, though this class of drug is very good, but because of the fact that she complained of recurrent UTI in the past, and this drug is known to precipitate UTI, that is why we are not using this drug. So the idea of giving you to this talk last 40 minutes was to change your habit of managing type 2 diabetes in a different way. Don't consider the person as only having type 2 diabetes. He may be having other risk factors. He may be having complications of type 2 diabetes. So we need to address each and every issue to actually address managing a patient with type 2 diabetes. So it is what is known as nowadays a patient-centric approach, which talks in terms of cost and benefit ratios. It also talks in terms of lifestyle measures. It talks in terms of diabetes self-management and education support. We also have talked about customized therapy, focusing on individualized targets. We also have talked about medical nutrition therapy. Then drugs like these are add-on drugs to metformin, which is the sheet anchor of managing type 2 diabetes. Glinides and short-acting sulfonylureas and alternative options. And rapid-acting insulin analogs may be considered over regular insulins when postprandial hyperglycemia is concerned. Okay. So with this, I'll thank Sangeeta, I hope I
सर
have been able to finish well
सर
on time.
मुझे आपको थैंक यू बोलना है for preparing
No,
such a
Sangeeta.
lucid
No, thank you, sir. It was really nice.
Thank you, sir. So, if there are any questions, I am ready to answer the questions.
You can write in the chat box your questions, then we can take these questions one by one. I know diabetes is such a big, topic, and doing justice to this in half an hour or 40 minutes was a very difficult task. And it has both non-pharmacological treatment, pharmacological treatment, and amongst the pharmacological, we have hypoglycemic agents. Then we have insulin. There are various issues involved with the insulins.
So they are only, I think one question they always ask is, can you share your slides? Sangeeta, I'll share my slides with you. So you can put a link in your website so that people can have
I
a view.
think you don't have to worry about this because YouTube
Yeah,
recording will be
recorded is
available. So
right.
एक हफ्ते में मतलब I think that would be sorted out, and we will circulate that, so you can look for that.
So one
Sir,
question is there any clear indication when to switch insulin from ADAs? Now, the one important issue which in Indian setup of ideally, please understand, ideally, every person should have been on insulin. But because of the fact that we have equally good drugs available, which are oral, which are easy to take, that is why. So one important thing is that over a period of time, all these drugs become ineffective because of various issues. So finally, most of the patients with type 2 diabetes will require insulin. Some of the clear-cut indications are if the patients develop complications, if the patient has a severe hyperglycemia which is not responding to oral medication, then we can switch to either insulin alone or a combination of those medications which the patient was taking and insulin. Start with the basal, then we can switch to basal bolus. Of course, if the patient is hospitalized, now that is one of the major indications of giving insulin. When the patient is hospitalized, then these drugs will not be that effective. Then we have to rely on insulin because we require a very meticulous and a close control of the blood sugars. Postprandial hyperglycemia, which medicine to be given with insulin? Postprandial hyperglycemia can be addressed by short-acting insulin, as I said, or drugs like shorter acting either sulfonylureas or you have those glinatides, metaglinide and other medications, right? What are the key issues of impact of health literacy? Very, very important. Health literacy is one of the very important components for anything, be it hypertension, be it diabetes. They need to understand what is the thing which they are taking. They need to talk about uh, uh, their medication. What is insulin? They need to be talk about sulfonylureas. It is our duty. OGT should be done after 2 hours of 75 grams. Yes. Brittle diabetes is the one where there is a fluctuation of diabetes. On one hand, you will have a blood sugar of 65, 75. On the other hand, you will have a blood sugar of 400. So this should ideally be actually dealt by an endocrinologist or a person who is specialist in this therapy. Lot of thank yous coming, Sangeeta, all to you, because you're the one who's been actually carrying this very, very important process of educating the mass, carrying the torch. And I must congratulate you for this beautiful effort which you are doing for last, I've seen you for last 30 years, you're doing the same.
I
Great
have been
effort.
your student. आपने पढ़ाया मुझे.
What's the drug to be given along with metformin? It can be either. Now, that second choice is your patient-centric approach. If the patient is poor, add sulfonylureas. If the patient can afford, or if the patient has reimbursement issues, then SGLT2 inhibitor is the drug of choice for the second line drug. Do we have data on what percentage of diabetes patients have foot ulcers? Yes, the exact data can be found from these studies, but overall, after 10 years of duration of diabetes, almost 5 to 10% of the patients can develop some form of a foot complications. But they are generally the terminal complications. Please mind you what I'm saying. So if the patient has developed a coronary artery disease or a stroke, he can still have a longer life. But once the patient has developed peripheral vascular disease, then it's the last sort of a stage in the life of a person. How do we have data on percent of the foot ulcer? Foot ulcer. One question has come up 10 times. Often patient needs to follow up if patient has microalbuminemia. Every 3 months, you can follow the patient for microalbuminemia. Every 3 months, we need to do it. Thank you. Thanks, NPC. Thanks for
नहीं सर, कुछ क्वेश्चन ऊपर भी चले गए हैं.
आप बता दो अगर आपने मैं जरा इसको
हाँ,
खड़ा
जरा
कर
मैं
लेता हूँ.
स्क्रॉल करती हूँ. There is a question. There is a case scenario here. 60-year-old male on ATT, uncontrolled diabetes. Patient does not want to take insulin. He is on sitagliptin, dapagliflozin, metformin, and metformin plus glimepiride, pioglitazone, and fasting blood sugar is 240.
So, Sangeeta, this is the case where we need to sit with the patient. We need to make him understand that your uncontrolled blood sugar can make your tuberculosis treatment, havoc. So, what is important is that we need to empower him about how insulin can help him. And once the patient is started on insulin, there is a mindset that it will be lifelong. Tell the person that this insulin is being given for some time. This will bring down your blood sugars to a reasonably good level. Let the drug be allowed to act, and then it can be settled. So the only thing which I have for this patient is to start a basal insulin, 20 units at night, and gradually he will improve because he's already been on, metformin, sulfonylureas, pioglitazone, dapagliflozin, and sitagliptin. All class of drugs have been added. So if now these type of patients have what is known as insulinopenia. So they have insulin resistance to begin with, but now they have insulin deficiency. So the only way we can tackle them is to start them on uh,
Sir,
A1.
इस तरह की prescription is not uncommon. My brother-in-law, I was recently looking at his prescription. He had 5 oral hypoglycemic agents. Does this
उसकी
help,
जगह एक
adding?
इंसुलिन का फायदा क्या है कि 2 यूनिट से 200 यूनिट तक दे सकते हैं। एक ही इंजेक्शन में हम आपको ज्यादा डोज दे सकते हैं। वाइल medications medications are fraught with the danger of causing hypoglycemia at one time and hyperglycemia at other time. So we need to be careful about that.
I think there was one question about how often patient needs follow-up if patient has microalbuminuria.
Every 3 monthly. We don't have to call them every week or every 10 days. Every 3 monthly is an ideal time when you should follow up the patient.
Then how to control on ARB inhibitors and metformin?
With insulting, I don't know. I couldn't understand the question.
I think it must be insulin.
Hyperemesis gravidarum is actually a different where the drug which is very effective is melatonin. But how to treat diabetes with hyperemesis? Hyperemesis is only a transient phenomena which occurs in the first trimester. So you have to add a drug. There are certain more medications which I did not talk about. There's something now hydroxychloroquine is being used, bromocriptine is being used for treating diabetes, but they are not evidence based. So I did not talk about that. So hyperemesis gravidarum have to be treated separately. Type 2 gestational diabetes or diabetes during pregnancy has to be treated with insulin or at the most metformin if the patient has an underlying, obesity and other things.
Sir, एक बड़ा important question है fasting and these medicines for the diabetes, and I think there is one question in this regard also. कई बार ऐसा देखा है कि patient खाना we don't instruct them properly. Fasting कर रहे होते हैं, they take their dose and omit their meals or their because fast
Yes,
में एक
very
particular
very important
type की
question.
meal होता है, तो वो मतलब meal type change हो जाती है उनकी. तो can you just tell us
So it is
something about that?
extremely important to make them as your friend. The person with diabetes has to be a friend and he should also be empowered. Drugs like metformin are given postprandial because they can cause some side effects of GI disturbances. And if you start the patient metformin before meals, the patient will come back to you कि दवाई बेकार दी आपने तो मेरा पेट ही खराब कर दिया. Sulfonylureas, because they act for the postprandial thing, so they have to be given fasting, they have to be given before meals. But sulfonylureas and insulin, when being given half an hour before the meals, person should be clearly advised, especially when you are giving short-acting insulins, that the food should be in front of you. It should not happen that you have taken an insulin and suddenly your friend has arrived or your neighbor has arrived and you have stopped, you have not, you have forgotten about meals. So it should be special instructions that drugs like which cause hypoglycemia, which are insulomimetic, should always be given before meals and the food should be available when you are taking the medicines. On the other hand, there are drugs like acarbose, there are drugs like metformin, pioglitazone, they can be given. Again, acarbose acts postprandial, so it should be given with the meals. There are drugs like metformin, because it causes GI disturbance, it's given after meals. pioglitazone and DPP4 inhibitors can be given anytime.
सर एक और चीज बड़े कॉमनली मैंने देखा है पब्लिक में, बिकॉज दे आर नॉट एजुकेटेड अबाउट लो ब्लड शुगर, हाइपोग्लाइसीमिया कैन हैपन इफ दे चेंज द डोज और द टाइमिंग और द मील टाइप। तो कई लोग ये बिलीव करते हैं कि मेरे को तो मीठा मना है, तो क्योंकि हाइपोग्लाइसीमिया में मीठा देना पड़ेगा, दैट 15-15 रूल इज देयर। तो कैन यू जस्ट इलैबोरेट ऑन दिस?
So I think you have touched upon a very, very important point of discussion, which is hypoglycemia. Each and every diabetic should have one experience of hypoglycemia in the presence of a doctor, ideally. So, invariably, when you end up having hypoglycemia, in fact, I had a phone call from one of the very senior physician who called me day before yesterday that he's inadvertently taken twice the dose of insulin. What should he do? I said, you look for your blood sugars, look for symptoms. Remember that there are two types of symptoms of hypoglycemia. One is neuropathic symptom, neurogenic, when you have neurological symptoms because of low blood sugar in the in your brain. But they occur much later. Earlier ones are warning signs symptoms, which are because of the body's effort to improve blood sugar. So these are symptomatic, symptoms like nausea, hypoglycemia, feeling like eating something, sweating, palpitations. In elderlies, in patients who have a very long-term diabetes, these symptoms may not be present. Straight away, they may become unconscious, or they may develop, neurological deficits. So it is extremely important to make them understand that taking a drug is as bad or good as not taking a drug if it is not being taken properly. So there are two classes of drugs. One are safe drugs for hypoglycemia because they will cause the blood sugars to become normal, will not cause hypoglycemia. But second are the drugs which produce insulin from your pancreas, like sulfonylureas, like metaglenides. So they are the ones which are more likely to cause hypoglycemia. So whenever these drugs are being taken, we should make them aware about meals should be taken regularly. Second thing is, if suppose you've gone for a party and I've gone for a party, I want to have a gulab jamun, doesn't matter, you should prepare yourself for that. So either you reduce your food in the afternoon or you increase your insulin by 2 or 4 units because you are likely to indulge in a party culture. On the other hand, when you are at home, you're stable, or when you don't want to eat, you have to reduce the dose of insulin. So it is important for us to make the person understand, because it's a lifelong disease, the patient should be empowered about what all problems can occur in such individuals.
सर एक और प्रॉब्लम होती है सिक डे पे, वॉमिटिंग हो रही है या फीवर हो रहा है, तो जनरल टेंडेंसी होती है कि उस दिन वॉमिट कर देते हैं क्योंकि खा नहीं पाए हैं या
वो
कोई
ये
और।
नहीं पता होता कि that vomiting can be due to hyperglycemia. The simple answer to that is, one is of course there are drug holidays, SGLT2 inhibitors or ACE inhibitors. When you have acute problems, when you have acute complications, then these drugs may be detrimental. So we have to avoid taking the drug. But on the other hand, if you have any acute symptoms, check your blood sugar first. Is it because of hyperglycemia or is it because of hypoglycemia? If your sugars are in the normal range, you are having symptoms, then obviously if you're having persistent vomiting, you're less likely to eat, then you should maybe skip one next dose of insulin or reduce the dose of insulin. Then subsequently, if you are improved, you have to eating more food, then you should increase the dose. So it has to be individualized based on the situation.
एक इन सभी पेशेंट को हाइपो किट अपने पास रखने के लिए जरूर बोलना चाहिए, वी डोंट
हाँ, एक
प्रिपेयर आवर
कॉफी हो
पेशेंट।
गई या एक बिस्किट्स हो गए, कुछ ऐसी चीज रखें. Many times you are at home, so you can have a kit with you. Yes, there are kits available, man-made kits available, which can be given to them. चॉकलेट्स होगी, चिक्की हो गई, ये पट्टी हो गई, ये सब चीज़ें ऐसी होती है कि जो आपको हेल्प करती हैं शुगर को इमीडिएटली बढ़ाने में. तो दिस कैन बी केप्ट इन होम. वेरी गुड सजेशन.
हाँ, रेडीमेड जो जल्दी क्विक एब्जॉर्ब हो जाए वो लेना चाहिए। चॉकलेट और एरेटेड ड्रिंक्स आर नॉट प्रेफर्ड, वो देर से एब्जॉर्ब होता है। तो रेडी मतलब कैंडी या शुगर, सिंपल चीनी भी हो तो दैट विल वर्क हियर।
There is a
मस्ट
question,
एजुकेट यू।
Sangeeta, There's a question, is metformin also given PCOS? Yes, it is one of the treatment of choice for polycystic ovarian disease, but it was not the topic of today's discussion. This is a very, very effective drug apart from weight management, and metformin is also one of the very effective drug which is given for.
There is a question, which measure for monitoring diabetes is better? Blood sugar, fasting, PP, or HbA1c, or continuous glucose monitoring?
Now, that's a very good question, and I did partially try to answer this. See, please understand, if you are looking at an acute fluctuation, day-to-day fluctuations, then you have to look at blood sugar as your this thing. Many a times we first do fasting blood sugar. We try to keep our blood sugar fasting below 100 or between 100 to 120. Then Indian patients have a subset of, there are subset of type 2 diabetics who have prendial hyperglycemia, who have postprandial hyperglycemia. So in which case, then we also have to, what I suggest to my patient is that during a week, suppose if you have to do a monitoring, do fasting and PP on one day, that is before breakfast, after breakfast. On second, third day, you do before lunch and after lunch. On fourth, fifth, sixth day, you do before dinner and after dinner. And one sugar you do on Sunday at 2 o'clock, 1 o'clock. That will give you an idea. How is my meal? How is my parental sugar? Based on that, then we can address the issues individually. Routinely doing a fasting BP in the lab will not serve the purpose if you are eating a very less breakfast and a very heavy lunch and dinner. So we have to address, especially a person who's on insulin, has to monitor his dose of insulin based on the blood sugar profile. But we normally don't ask the patient to chase the insulin, chase the sugars. Rather, start with the basic dose. Let's say start with the 10 units. Look at your sugar levels. If they are very high, they're still uncontrolled. Go step by step. Every second day, add 1 or 2 units till your fasting is controlled. Then you address the postprandial issue with the shorter acting insulins. So it's a step by step approach.
If a patient is having 3 plus sugar in urine, then should we refer to nephro department?
No, please understand. This is a very, very important question. 3 plus protein, yes. 3 plus sugar can be due to one of the most important drug which we nowadays advocate is SGLT2 inhibitor. SGLT2 inhibitors act by reducing the blood sugar by causing glycosuria. So obviously a person who was having 1 plus blood sugar will have 3 plus, urine sugar if the person is on SGLT inhibitor. So this needs to be explained to the family. However, if the patient has proteinuria of 3 plus, ideally the person should go to a nephrologist, get the proper management done, and then come back to you for maintenance of that medication.
I think we have all answered, all the questions. We haven't missed anything in the chat.
But you have not given them their
Reverse,
certificate. They are more interested in.
reversal of
Certificate.
diabetes is possible. One question we have left behind. Is there
Which one?
possible of reversal of the diabetes which they said in the market?
Very good. What question is this? Can you just repeat it? Looks like very interesting. I am not able to see that.
Was very old question.
Any?
Can we reverse diabetes through medications? Diabetes
Oh.
through medications.
If you listen to, now this answer is no. Through medication, no. But if you listen to Baba Ramdev, he advocates that every day at 8 o'clock that he claims to cure diabetes with the help of yoga. I am not an advocacy of that, but I can tell you that I have seen individuals through their lifestyle, through their medical nutrition therapy, have been able to bring down their requirement of drugs to minimum level. So it's a lifelong disease. Once the diabetes, always the diabetes. But with your effort, because it's also a silent killer, it's also a lifestyle disease. So if you improve your lifestyle, if you do 1 hour of yoga, if you do 10,000 steps daily, if you do swimming, if you reduce your diet, your sugars can be controlled. But the mind is such, our behavior is such, the moment the greed of eating actually prevents us from controlling our diabetes.
कोई चीट
Otherwise,
डेज अलाउड होते हैं क्या?
हाँ, cheat days allowed है, देखा?
Days allowed
cheat
होते
days
हैं।
करेंगे तो फिर शुगर तो कंट्रोल नहीं होगा.
नहीं, कभी कभी, क्योंकि ऐसे कभी जिस चीज को बिल्कुल मना करते हैं तो उसके लिए ज्यादा
Yes,
क्रेविंग हो जाता है।
yes. So they are allowed, yes. occasionally.
सर ये वाला एक क्वेश्चन है, अगर रैंडम शुगर इज 400 and above but patient is asymptomatic, should we start with insulin?
Yes, I think ideally any person who has a persistently high 300 blood sugar, there is something known as glucotoxicity. So persistently high blood sugar, even if the patient is asymptomatic, we should try to bring down the blood sugar. If the patient has not been started on oral hypoglycemic agents, then he should be given insulin for at least 2 to 3 weeks. Let the sugars come down because they will be very effective in bringing down the blood sugar. Or we can offer the other alternative is to start them on sulfonylureas. Metformin will take time. They will not be able to bring the blood sugars immediately very soon. So either put them on insulin or we can try a 1 to 2 milligram of combination of metformin and sulfonylureas so that their blood sugars. But if they are already on, then the person should ideally be given insulins.
Sir, I think ये तो मतलब there are lot of questions on this, पर insulin technique कैसे है, there are a lot of other things. I
Yeah.
think we cannot
So
do it in all in one session here. Maybe we sometime we will have
more
a
important
session.
is, Sangeeta, we must teach our patients how to take insulin. That is very important. To tell them how to measure the dose and how to take insulin, which is very simple, but it has to be taught.
एक ये जो क्वेश्चन है, कैन कार्बोहाइड्रेट फ्री डाइट बी फॉलोड ऑन लॉन्ग टर्म फॉर रिड्यूसिंग डायबिटीज? आई थिंक डॉक्टर सिंह हैज ऑलरेडी एक्सप्लेन्ड इट. वी नीड टू बैलेंस ऑल थ्री, कार्बोहाइड्रेट,
Yeah.
प्रोटीन एंड
So how
फैट.
can you avoid carbohydrates? कैसे खाओगे? क्या प्रोटीन ही सिर्फ कोई इवन प्रोटीन में भी थोड़ी बहुत तो कार्बोहाइड्रेट होंगी, बट मेक
नहीं
इट
तो
मोर कॉम्प्लेक्स. हाँ जी.
वेट लॉस करने के लिए लोग कार्बोहाइड्रेट कट कर देते हैं, बट एक्चुअली
हाँ.
देन प्रोटीन ब्रेक डाउन स्टार्ट्स, इट इज
Starts
हार्मफुल
with yes,
एक्चुअली.
ketosis. So better is to take carbohydrates, but in a complex form. और कटोरी छोटी करो. The most important thing is quantity को कम करो. So automatically it
पोर्शन
will.
पोर्शन साइज
Portion size.
डिसाइड कर लो एंड स्टिक टू दैट पोर्शन
Yes,
साइज.
yes, yes.
डायबिटीज में वी मे हैव फ्रीक्वेंट मील्स बट स्मॉलर मील्स,
Yeah.
एंड पोर्शन साइज शुड बी
Portion
फिक्स्ड.
size should be reduced.
आई थिंक एक और क्वेश्चन है.
हाँ,
यंग
क्या है?
फीमेल पेशेंट विद HbA1c 13.6, हाउ शुड वी प्रोसीड विद द लाइन ऑफ ट्रीटमेंट?
So obviously 13 is a very, very high, dose, high HbA1c, and she's a young patient. So most probably she has type 1 diabetes. So the most important thing is in such a degree of hyperglycemia, the blood patient can go into ketoacidosis. The body starts to utilize alternative pathways of energy. So they go into ketoacidosis. So ideally this patient should be admitted in the hospital, should be given fluids because it will cause a lot of dehydration, such a high degree of hyperglycemia. So it should be managed, should be put on short-acting insulins, and once the HbA1c or the blood sugar levels come down, then they can be stabilized. Then we have certain modalities to test whether she has type 1 or early onset type 2 diabetes. Type 2 diabetes we can get along with oral medication, but if the patient has type 1 diabetes, then the only treatment is insulin. So the lady or the girl has to be on a long-term insulin.
आई थिंक आप सर कहते हो कि अटेंशन स्पैन लिमिटेड होता है ऑनलाइन सेशन का, बट यू सी वी आर हैविंग सो मच ऑफ क्वेश्चन एंड आंसर्स.
Yes,
यू नो
I understand that. This is an important this thing. Do you have to start with insulin? Blood sugar fasting is 400 plus. If on metformin or can we start sulfur? I have answered this question. Such a high degree of blood sugar can only be controlled by starting insulin. Please make the person understand that this is only a short, because they don't want to be on lifelong insulin. Tell them that this is only for some time. Once their blood sugar is under control, because there can be underlying, always look for the precipitating factor. Look for whether they have stopped taking medication, look for any infections, look for any acidosis, look for any cardiovascular event which may have been precipitating this high blood sugar. So look for the underlying cause and treat the person with insulin.
I think with this, I think we've exceeded quite a lot of time.
I've talked about HbA1c's fallacies. Someone has talked about HbA1 fallacies. Yes, especially in patients with hemoglobinopathies, especially in patients who are on dialysis, especially in patients who are getting erythropoietin, there are discrepancies that has to be looked into.
I think with this, I think all of you have filled the post test. We have around 150 pre-test was taken by more than 220 people, but we have got the post link only for 150 participants. Please, this link is open. You can finish it after the session also, but try do open that link so that you can fill it later. I think with this we can close. Dr. Srivastav is here. Can you just, may I request you to, just close the session?
Sure, ma'am.
I mean, I can only say this much, sir. With the level of the participation, we have been conducting these types of things, but people could connect with your talk. They were able to correlate, and it was extremely, extremely educating, at least personally for me. Though I had another commitment, but I, I just purposely, in fact, thought of attending the full session. And we are extremely grateful, sir, and we look forward to your continued guidance and support in this endeavor.
Thank you very much for giving me this chance. And I am, again, Sangeeta, thank you for, I always
My
look forward
pleasure.
to sharing whatever knowledge I have with everyone. This is the thing which will go with you, so it should be shared. Money will stay here. It will not go there.
Yes, and that's why, NHSRC, they make a, YouTube recording also, so anyone who has missed this session can go through the YouTube this thing. Annapurna, some of them are writing that they have missed the pre-test, but they have taken the
The time has
post-test.
exceeded for the pre-test. Now
I
we
know, I
can't
have
take it.
posted the link also for that.
Yes, ma'am.
What do you do with them? Just
Uh,
think about it. They
Thank
haven't
you, sir.
taken pre-test. Thank you, sir.
Thank you
Thank you
again.
once
Thank you
Thank you.
again.
again.
Thank you.
Thank you, sir. Even we thank you on behalf of NHSRC and DSPRUD for taking a very good, insightful, and lucid presentation from your side. Hope the many have taken the benefits from your session. Even I have increased my knowledge after many days regarding the diabetes mellitus. I also thank you, Dr. Sangeeta ma'am, for continuously supporting and giving us the resource person like you for all these 5 sessions. I even I extend my special thanks to our Jain Srivatsa sir, who is supporting from the first session, first STG lecture series sessions, which is started in September. Also, I thanks all the participants. Some are from the first sessions. We are seeing the same people, and we hope the extra colleagues they are bringing from their own working place. I also extend my thankful to all the participants. The next session will be held on 18th of February on Dog Bite. Hope the support from the participant will be continued, and this session recording will be done, ma'am. So participants will get this on before Wednesday of the next week, so that within 3 to 4 days it will be uploaded in the YouTube. And also your certificates will be come through your mail only, which you have registered to the mail ID. You will get in within a week. Thank you, sir. Thank you, ma'am. Thank you for
Beta.
all the participants for supporting in conducting this session. Thank
Thank
you
you,
all.
Annapurna, for your enthusiastic arrangement. You
Thank you,
ensure
sir.
everyone together.
Yes,
Thank
I
you.
think we should thank her, for, back end support is equally important,
Absolutely.
to see to it that they get the certificate, because then we keep getting the queries also, and YouTube, all these things. Thank you, Annapurna.
Thank you, ma'am. Thank you so much.
Okay, I'll share the links with you. You can edit those.
Sure, ma'am. Sure. Thank you,
Okay.
ma'am. Thank you all.